It's a pleasure and honor to be here in Kuwait. I'm going to talk about the recurrent pelvic-ureteric junction obstruction, how to avoid and how to manage. I have nothing to declare. This is my hospital in Dubai, and this is our Cancer Comprehensive Center and Mohammed bin Rashid University, which we are affiliated with. And we have just signed an agreement with the Intuitive Surgical to be a designated first Da Vinci robotic surgery epicenter in the region, actually, which is very nice. When I hear Dr. Al-Awadi yesterday speaking about many Swedish urologists' contribution to the urology in Kuwait, I just add this picture of my university where I trained in Stockholm at the Karolinska University Hospital. So to easy answer the title of this lecture is how to do it, is how to avoid it is not to do it, because if you don't do surgery, you don't have any complications. How to manage is refer to someone else, and then the problem is easy solved. This problem is actually like the Vikings. It's very uncommon, and it is challenging for both the patient and the urologist. Looking back at the history, in 1949, actually Anderson and Heinz described the open dismembered biloplasty technique to correct PUJ obstructions. This technique was very versatile, safe, and effective, resulting in very high success rate. But if we look at the original, this is the original pictures. It's slightly modified now when you're doing the Anderson-Heinz technique. At that time, you do the L-shaped resection and do the suturing, the anastomosis. The causes of PUJ obstruction, we have 80% intrinsic causes and 20% extrinsic causes. The intrinsic causes, we have atresia and anomalies, high insertions of the ureter into the pelvis, ampullary morphology of the pelvis, and the altered pacemaker function. It is a neurogenic mechanism that can cause the pelvic-ureteric junction obstruction. And with the extrinsic causes, we have anomalous crossing vessels, secondary stenosis due to an inflammatory process. Of course, the essential to avoid any recurrence is to do a successful pyeloplasty. And to do a successful pyeloplasty, we have to preserve the vascularity of the ureter and the pelvis. You have to do a widely patent, tension-free, and watertight anastomose. You have to avoid kinking or twisting of the anastomose. And this can be avoided by having a good isolation of the pelvis and the ureter, and to pay attention to the first suture point. Each crossing vessels should be recognized. In case of evident obstruction, it should be transposed. And some lower pole vessels couldn't be recognized maybe as the main cause of PUJ obstruction during the first operation, because they became adherent to an inflamed renal pelvis and could have an inferiorly displaced by a big renal pelvis without an important cause of obstruction. Here we can see some short videos about. To go back. Let's see. So anyway, the principle is the mobilization of the colon. You identify the ureter, you're dissecting and removing the stenotic part, and then doing a proper anastomosis. What are the main causes of recurrent PUJ obstruction? Of course, severe peripelvic and periureteric fibrosis due to urinary extravasation is one of the most important factors. Ureteral ischemia, failing to diagnose a lower pole crossing vessels, and actually I was surprised to find this between the causes, but it has been reported in many cases in the literature regarding one of the causes of recurrent PUJ obstruction. Poor preoperative split renal function, the presence of renal stones, the patient age, especially in younger pediatric patients in less than 6 months, diabetes mellitus or prior endopylotomy are the main causes for recurrent PUJ obstructions. Indication of the treatment, of course, as for the primary or the secondary obstruction, you have a symptomatic obstruction, you have to document your obstruction, and if you have a complicated obstruction with recurrent infections and presence of renal stones. The preoperative assessment is essential, of course. You need to do a CT scan. If it is not possible, an MRI, and this will give you an idea about the anatomy, and then you have to document the function of the kidney by doing a MAG3 function. Some people think that it's maybe enough with the CT scan and you can do, but it's good to document the function and the obstruction before and for follow-up after the treatment for the patient. The management options available, you can do an open surgery, you can do an endoscopic management, laparoscopic, or robotic. Robotic has been known as can minimize the difficulties and technical challenges in some reconstructive cases. But again, robotic surgery, there is no definitive evidence of open or laparoscopic or robotic superiority in this case. But again, as I said, robotic is a non-advantage in complex reconstructive surgeries. The approach, you can do the common approach by mobilization of the colon, or you can do the transmesocholic approach. This is applicable in thin, young patient and in pediatric setting. As you see, you can see the dilated renal pelvis directly, and you can incise the mesocolon and get to the site of obstruction. The techniques available, again, the most used technique and successful one is the Anderson-Hines dismembered pyeloplasty, where you completely transect and resect the stenotic fragment. You do a widely patent, water-tight, tension-free, spatulated anastomosis, and you place a double G stent to protect the anastomosis. But there is other techniques, non-dismembered techniques, and it's very important to know at least one of these techniques or know the indications of these techniques, because you are not always able to do the Anderson-Hines technique. We have the fingerplasty, which can be used in shorter strictures, no crossing vessels. You have the flap-plasty in long strictures, and you have the YV-plasty when you have a higher insertion, no crossing vessels, or redundant pelvis. What are the surgical challenges in redo pyeloplasty? Of course, we have the scar formation at the previous anastomotic site, the fibrosis of the surrounding tissue, adhesions to vascular or intestinal structures, obliterated surgical planes, and of course, decreased vascularity of the ureter. This is why you need to plan and to prepare before you perform any surgery. You need to gather first information about the primary surgery, use the standard port placement, whether if you do it laparoscopically or robotically, incisions overlying the scars of the primary wound, surgery to minimize the aesthetic impact, and then transposition of any crossing vessels. The risk in these surgeries, of course, you have a difficult dissections of unclear planes. You can damage the nearby structures, particularly the vessels, and you may require an extended resections to find a healthy and a well-vascularized tissue. But sometimes the redo is not feasible. Of course, when you have a shorter ureter, when you have an extensive scarring, and you have an internal intrarenal pelvis. This is why you need to think, what are the other possible solutions? As I mentioned, the other pyeloplasty techniques that I mentioned, you need to know about them, how to perform them. Maybe you need to do a renal pelvis flap, or you need to do an endoscopic dilatation or incision, ureterochalicostomy, or ileal ureter replacement are one of the options. And nowadays, the use of the buccal mucosa is one of the newest options that can be used for the recurrent pelviuretic junction obstruction. Just a few words about the endopylotomy. It can be done in a retrograde manner or an antegrade manner. You have to dilate sometimes, according to Dimitris Bagley, you have to incise with a laser fiber, dilate, and see the extravasation of your contrast, and then put the stent. Comparing the success results of the endopylotomy with the redo pyeloplasty, the success rate of endopylotomy is around 75%, while the success rate of redo pyeloplasty is higher. It may reach up to 90% in many cases. So again, going back to the title of this, how to avoid it, of course, we need to standardize the technique. And this is regarding the primary surgery, because if you do a proper surgery, you hopefully don't get any problem. You need a well-trained surgeon, and again, do it properly. How to manage? You need to have a high-skilled team with a high volume, because as I said, this is a very uncommon, and you need to have a more experience to deal with this situation. So, but on the other side, it's difficult to standardize the technique because of the low volume of it, and the treatment need to be tailored to every patient. Refer to high volume centers who have experience dealing with these problems. In the literature, you can find using interrupted sutures, synthetic absorbable monofilament sutures, always stenting, consider abdominal drainage. I'm in doubt there is no actually big evidence that these may be very helpful. But again, be well prepared, because the person who is well prepared has already won half of the battle. And thank you very much.